Welcome. Are you excited? Quiet, but excited. So this is our 6th year. It's 10 years since we started. It's 20 years since the foundation program started. Does nobody give a cheer for the foundation program? It's 20 years. I was in the Antipodes recently hearing how wonderful they think our foundation program are, so maybe you should go along to the foundation program sessions. Anyway, since 2015, a few things have changed. If we look back, we hadn't had a Trump. We still had a Queen. We hadn't had any doctors' strikes. But we had doctors in training, and we have educators. We had enthusiastic educators. We still have enthusiastic educators. So thank you all for coming. We've tried different formats for this. We've evolved it over the years based on feedback. This time we decided to have an all face-to-face conference. At the time we decided, we didn't know how difficult it would be or how important. Now, as we have a face-to-face conference, I'm going to make you all do something. You have to turn and shake hands with the person beside you on one side, and then on the other side, and then behind you, and then in front of you. If there is someone in front of you, you're excused on the front row. Okay? Now, it's all uncomfortable because it's touchy-feely, but come on, you're educators. Okay. Right, come on. Don't get too carried away here. Stop hugging each other. Right, I'm going to get onto some serious stuff and sober you up. There are 1,200 people registered. Now, there's some good news for the abstracts. All presented oral and poster abstracts will be published in the Clinical Teacher. Now, there are no fire alarms planned for today, so if the fire alarm goes, you follow the wee green men and instructions, and we should evacuate the venue in a calm manner and assemble at the main entrance. As you've noticed, we have some sponsors. We have some Welsh cakes. Please, could you visit all the different sponsor tables and find out about some of the organizations hosting this conference and also our sponsors. There'll be no recording of the parallel sessions for on-demand or live streaming this conference, but the plenary sessions will be. And for speakers, can you let the audience know if you don't want delegates to take photos and put you off? Now, if you want to ask questions, can you come to the mic? There'll be 4 dotted round the hall to allow you to come and ask questions. And I've done this in every single DMEC conference. I've forgotten to say who I am. So, I am Shona MacLeod. I'm the very forgetful Director of Education and Training who always forgets to introduce herself. And I would like to introduce Namita.
Morning, everyone. I'm Namita Kumar. I'm the National Dean for PGMDE in NHS England. And we've been co-chairing this committee for a few years now. But for me, it is so lovely to see the excitement. You were all smiling when you were registering. Those of you that could use the registering machines, that was an observation, but it's so lovely to see you. And really, for all the hard work, it's worth it. And we're really hopeful that this won't be the last DMET. There will be another one, I'm sure. So, have you all downloaded Slido? Can you do that, please? Because you would expect at an educational conference, there'd be some audience participation. Can you do that?
This is why it's good that you all shook hands, because anyone who's my age can now ask someone younger who's sitting round them to help them download the Slido.
But I have to say, I think age catches up with all of us. Okay, are we able to go to our questions? Excellent. So, our first question is, where are you from?
England's a bit of a cop-out. Can we have a bit more specificity there?
Yeah, like Wellington House in London.
There's a lot of folk from Leeds. Now, I know there's lots of people from Scotland here, so either they can't work the thing or they're sulking.
There's northeast down there. Someone once asked me, where are you from? I said, the northeast. And they went, London. I went, no. Okay. I'm sure there are at least 2 people who aren't from the United Kingdom. Okay, that's great. So that really does reflect that we have managed to get people from far and wide.
Oh, good, got a big one from Scotland now. They've pressed it lots of times.
Okay, excellent. Can we move to the next question? Which area do you represent? So, postgrad medical, undergrad medical, manager, postgrad dental, other profession, undergrad dental. Okay, so as expected, generally postgrad medical, but hopefully something for everyone, and we're all very conscious of that when we establish the programme. And can we have the next question, please? What is the most important thing you hope to achieve from attending DMEC?
Of course, they all thought about that beforehand, because they're all educationalists, and they had their learning objectives for the whole conference. Lunch. Food.
CPD points.
Well, you can get CPD points.
Well, hopefully you will get your CPD points. I think the networking, the connection, being face-to-face with people is so important. We are social creatures, and it is important that we do get in the same space and shake hands. New ideas, so important. Okay, thank you. So, not yet. We now introduce our first speaker, Jim.
Now, I'm delighted that Jim's joined us. The theme of the conference is a globally sustainable workforce. So we're starting off with a global expert. At the minute, we have lots of global events that are affecting you, our learners, the people they work with. We also heard from the Medical Training Review how important the global perspective is to doctors in training, how important sustainable living, global health, the environment, and the global workforce, and our current workforce also think globally. They're beginning to think globally about jobs. So I'm delighted Jim's come to join us. He's been director with the WHO for 12 years. He's been overseeing the development and implementation of evidence and tools to support countries in education, employment, and retention of their health and care workforce. He's looking for global health security, universal health coverage, and sustainable development goals. In order to do this, his portfolios included the WHO Strategy on Human Resources for Health, joint partnership working to implement recommendations from the UN High Commission on Health, Employment and Economic Growth, the Global Code of Practice from the WHO on international recruitment of health personnel. He oversees lots of collaborative networks and partnerships with academia, civil society, government institutions, professional associations, and unions. He's got a particular focus on data exchange, digital technologies, AI, and all those things that I'm sure I don't really understand. But he also focuses on equality for women and youth, which I do understand. Jim's actually a graduate from Bristol, and he went to the University of Leeds. He's published extensively, and we're delighted to have him with us this morning. Over to you, Jim.
Good morning, Birmingham, and a few people from the 4 home nations. And I think I saw Zimbabwe up on there somewhere, somebody from that. So a pleasure to join you this morning. I was asked by Shona and Namita to give you a global perspective from the vantage point of Geneva, and obviously the World Health Organization, 194 member states, all the professional associations, over 1,000 academic institutions partnering with us to produce evidence. And just as a result of some of that perspective, working with your ministers or your Secretary of State for Health here, though they do keep changing rather a lot here in the UK, working with them to look at some of the realities that we're facing globally around the health and care workforce. The presentation in 2 parts. Firstly, around some of the global data, the context and the trends that we have. As Shina said, this is something that in the privilege of the role that I have, we're continuously looking at the data evidence and trying to understand the patterns and the trends in that evidence and how that might inform policy. And so the second part will be taking some of that data and evidence and just giving you a few provocative thoughts on how that might apply to when we look at a single country, and in this example, taking the opportunity of the new 10-year workforce plan to translate some of that evidence into questions around what the different stakeholders here will be doing on that element. Obviously, when we look at data and evidence, we have to be open to queries on its validity. And so, I mean, this is a debate here that you have already. Patient waiting lists, how accurate is that data? The 350 million promise about funding in the NHS, another example of data being manipulated into a completely different perspective. And even just on the application, I was looking at this to try and see who's attending and from which fields and from what work, what areas, what countries, and what was the most common first name amongst our participants here today? 41 people are called doctor. Obviously, your parents were very ambitious when you think, but if you think about if our medical educationalists are having problems filling in forms, total triage, let's wait and see. Good luck to the GPs. So, this is a sort of global reality that around the world today, the multi-dimensional demands on health and care systems worldwide. You can read through this and You were from any newspaper that you've been reading, from any media feed that you have, the conflict and war, the climate change dominating our news, infectious disease outbreaks. Again, this latest influenza, this year's annual season, already filling up hospital beds. The realities that we face, common around the world. Gender and inequality, as Shona mentioned, something that we really care about. To look at some of the realities. 2/3 of the workforce around the world are women. We've got increasingly a younger push in education in terms of capacity and more spaces. So more people coming into the workforce than ever before. And so what are the dimensions around inequalities in the labor market, in the education market? And in the bottom right there, the big question that impacts everybody: money, financing. Who is paying for health and care today? And is there enough financing, liquidity, CapEx, OpEx in the system to allow us to be able to really fund and finance our ambitions that are in our policy statements? And this, just as perspective from the WHO database, and the WHO data is what countries report to the WHO every year in terms of their data. So they give us morbidity, mortality, public health, beds, financing, infrastructure, workforce data, and from that we're able to triangulate. And what you see around the world on that left-hand side, domestic spending, sort of over the last 20, 30 years, increasing in high-income, upper middle-income countries. COVID-19, the peak, money coming down. And this post-COVID dip is getting even steeper in terms of less investment, less public expenditure overall. Low and middle income countries in the blue and red at the bottom there, stagnation and even regression in terms of health spending. So there's less money by government into the system. And the right-hand side takes that red line at the bottom, the 5%, and regression into where the sources of funding are. And the biggest single source of funding in low-income countries now is out-of-pocket payment. People paying for healthcare themselves. It's the lottery of how you access healthcare. And what has the world been doing in result to some of this data? We've actually started to decrease our contribution to development assistance. This Labour government currently in the UK and England coming up with a policy which I would never have thought I would have ever seen, a Labour administration decreasing aid and official development assistance for some of the key issues around health, education, social protection. So financing is a challenge. If I look at it another way from the World Bank data, and this is just from last month, the end of November, in terms of the World Bank's projections from this data through till 2030, you've got this pattern. So the gray columns in the right of the two, in terms of where the public spending in low-income and low- and middle-income countries, we will not be investing enough public investment, public money, into our healthcare systems. And these are the same economies with the fastest growing populations in the world, where morbidity and mortality is highest, where disease outbreaks are occurring, where we still got endemic HIV, TB, malaria challenges, and the push and pull factors with climate and everything else. So this is a reality about our global healthcare systems are not fit for purpose. And that has an impact on Europe, and it has an impact on the UK, even if you're outside of Europe. In those health systems, then, which are being defunded, what's happening with our workforce? What we're seeing around the world is this increase in labor. It is the fastest growing economic sector for employment in the last 10, 15 years. We are employing more and more people in the health and social care economy. And that's driven by some of the clinical roles, which we're seeing, the big 5 professions, but also all other roles in the health and well-being economy. Research and development now in Europe, over 1 million new jobs have been created in the last decade. So we're putting more money into R&D, technologies, innovation, let alone the data on AI, which is changing every single day, and just how quick that's growing. As a result of this increase, global shortages are coming down, or the global shortage that WHO defines. And that trajectory, though, is slowing. And the speed of decrease is not going to be reaching some of the ambitions of 2030. And we'll still see over 11 million shortage by 2030 worldwide. Concentrated where? In the Africa and Eastern Mediterranean region, where again, countries with experiencing continuing conflict, continuing challenges with climate, continuing challenges with AMR, and all the burden of disease that we're just saying, and without financing. So there's no money, and there's potentially no people in these health and care systems to accordingly to get that done. And that's without then looking to Europe and having other shortages. So UK from the WHO perspective does not have a shortage against universal health coverage, but it has nationally defined shortages to improve and expand and develop and make sure that you're meeting the policy ambitions. Let's then look at some of the data specific. That's a big picture of all workforce. Let's look at some of the reporting on the medical doctors. And here we follow labor statistics. So your Department of Health and Social Care or your equivalent in the devolved administrations is responsible to aggregate data according to labor statistics. And so we have medical doctors is a 3-digit code, all medical doctors. Generalist medical practitioners, 4 digits. Specialist medical practitioners, 4 digits. 5 digits, we get into all the specializations, all the specialties around oncology, pediatrics, dermatology, surgery, et cetera, For nurses, any advanced practice roles that you may have would be the equivalent. And what are we getting? So we're getting worldwide this big increase from the early part of 2017-18, where we made it an annual reporting requirement to give us data on our big 5 occupations. Before that, it was a voluntary process. It then became a compulsory process. And so we've got all countries around the world reporting on the 3 digits, and about 80% 4 digits, but 0% reporting on the 5th digit classification of occupations. So WHO, as a result, is blind to what's actually happening, and I saw in most of you from postgraduate medical education, what's actually happening around the world in PGME. What is actually our impact for the money that we're spending? Let's look at our undergraduate data. What do we know? We have, again, pretty consistent reporting around the numbers, the stock of our undergraduates coming into, or all doctors at work. And the places where we start to see like 20%, 19%, 30%, just around some of the basic data. What is our capacity to graduate a doctor and put them into practice? And many member states, many countries, their information systems are not consolidating that data in a way that makes it comparable across countries. Here, even here with the 4 devolved nations, having that information, I tried to understand what was the capacity around medical doctors, and we had to go to freedom of information to get that data. It's just not publicly available because universities hide behind data protection. But are universities hiding behind that, or are they hiding behind financial information? The cost of their education with the performance and the outputs and the outcomes for it. One questions it. This should be public domain data. As scientists, you need that data to make improvements. Graduates, we get up into the slightly better data worldwide to make those comparisons. But that's before we even look at what happens when we go into practice. And what are our retention rates? What are our attrition rates? What are our turnover rates? I just saw one of the posters downstairs saying 50% of GPs are already leaving before the age of 30 in one of the NHS regions here. So having this data is, too many gaps that we have. Age, we do have good data on. And if you look at the far left-hand side here in the column that's circled medical doctors, for those countries reporting on age, medical doctors are increasingly, almost at 50%, reaching retirement age in the next decade. And so if you look across that, just to maintain our workforce in its existing capacity, without changes in population and growth that we have around the world, we need almost 1.8 million additional professionals just to maintain where we are to replace those who are leaving, if our models of care maintain. Many assumptions around that. But you show this age. This is a very aged workforce out of all the occupations. And so you have to start thinking that into your education and employment practice considerations. And are we doing that? If there's an aging workforce, if there's increasing demand, if there's increasing population need, are we seeing that translate into investment into our education, into your jobs, into your capacity to bring graduates through a system into employment and with a social accountability ethos, with an interprofessional practice ethos? So if we look at this from economic classification, low-income countries, low-middle income, upper-middle income, high-income countries, doctors and nurses, we have this data. I've circled there in red the data for undergraduate medical education. And high-income countries are producing only around 3%. And if you compare across those other economies, that's the lowest of all. So high-income countries are not investing in ensuring that we have this continuity of a workforce. And that's, again, with the assumptions that people would work 40 years, that they'd stay in their jobs, that they'd be full-time equivalents, would be one thing. And at that rate, we should be somewhere around 8 to 12% just to replenish, just to continue to build. But if you take on the fact that more and more people want this work-life balance, they want a mixed career, they want other things, they may leave at the age of 30 because of the attrition and retention problems, you actually need to be higher. You need to be at 12% and above to replenish, to replenish, to replenish. And if you're at 3%, the alarm bells are ringing in a big, big way. What happens if we look around the world? What's happening elsewhere? Because if next to the high income, you had the upper middle income countries up at 9%. Look at what China and India are doing. Over 300% growth in the last 20 years in medical education capacity. Expansion of medical schools, expansion of the cohort sizes and the overall capacity to graduate. Putting that new, younger, early career workforce into employment opportunities. And if I look at the UK in comparison, the chart would be very, very different, if we could get the data from Freedom of Information. What happens if you don't produce? If you're not graduating, this conference is about a sustainable workforce. If you're not investing in your own education system, where do you get your future doctors? So across, this is OECD data again from November, just published. It's the International Migration Outlook, and they got a whole chapter just on medical doctors and nurses in terms of what's happening around all the high-income OECD countries. And you can see this trend over time, growing, growing, growing. High-income countries, they're not investing in education. They are instead, through intentional policy decisions, recruiting from the global labor market. Now that's wonderful. The NHS, we firmly believe in migration and career opportunities. Firmly believe it. The NHS is built on that spirit. Opportunity for jurisdictional movement into the NHS with education and pathways, career development pathways, twinning, training partnerships. The Global Health Partnerships model here in the UK, anybody participate in it? Anybody working on global health partnerships? I see, yes, madam. There's a few there. It's one of the most successful, another one there. It's one of the most successful international programs around health partnerships in the world. You should be proud of it. It's a phenomenal achievement, developed by a Tory government, of all things. But this is the reality. If you don't educate, you go to the recruitment market. And here, those trends in foreign-born, foreign-trained continue to grow. And this is the average. The UK is an outlier, getting up to what, more than 40% now in terms of this year's intake into the medical register and the nursing register. So you're well above the OECD average. Talked about money at the start, financing. The education cost averted as a result of capturing labor, graduates from another jurisdiction. Over $170 billion just from 10 countries. $170 billion just from 10 high-income countries. Not spending money here in the UK, but taking the product from India, from Pakistan, from Africa, from the Caribbean. Taxpayers' money, often, not always. Investing in it, that education model, investing in license, investing in an early career, and then bringing that talent to the NHS. Saving all that money in undergraduate and specialty education, potentially. Not investing in our anchor institutions of medical university hospitals and giving you the resources you need to do your jobs well, but instead going to the market. And when you see the data like this, and this was from a collaboration with Canada. They hosted the G7 this year, which unfortunately didn't have a very productive set of discussions because of the Canada-US debates, let alone the G20 with the US removing itself from that. But they prepared this to actually have a discussion in the G7 on, is this ethical? Is this right? Are we doing the right thing as high-income G7 economies to be so dependent on the human capital investment from elsewhere to subsidize our health and care systems when they already have the greatest burden, the biggest shortages, the bigger problems around equity and equality and universal health coverage, let alone treating the next pandemic? It's a question. It's one that the BMJ, the BMA, the Royal Colleges, all of you are debating very much here as well. And tomorrow in Parliament, the all-party parliamentary group, the English Parliament, sorry, the APPG, the cross-party group, will be having a third it's got an inquiry on migration, and it's having the third hearing to talk about what is the UK response to this global reality. So as a result of all that data, all that evidence, all that trend analysis, and this is an interactive process with countries, continuously looking at their submissions, validating their numbers, questioning if we see differences in annual data and corrections, just to make sure that we're all on the same page. As a result of that consolidation of the expert groups, discussion then with the policy people, the parliamentary groups, and the representatives of the UK in Geneva occurs. And that results in a series of documentations that go to the World Health Assembly. And in this year, in May 4 documents on the health and care workforce. What is the reality around the world, our current understanding? What are the big picture issues? Where are the concerns around education, employment, practice, competence, investment? What should ministers be focusing on, either individually in their jurisdictions or across jurisdictions in partnership with other bodies? So the 4 documents looking at that, understanding particularly around migration and the debate there that are necessary. The issues then around the global code, migration, the general picture, and a resolution came out of it. So a decision, like a policy statement. So on the basis of the evidence papers, on the basis of the exchange, what should we be focusing on for the next 2 to 3 years in some urgency? And if any of you know from your universities, from your trusts, if you put 10 people in a room to talk about policy, I hear a few people sniggering already, it's always difficult to get consensus. If you put 194 countries in a room together and get them to achieve consensus, you can imagine how thrilling my job is. But we did manage to get some, the sort of lowest common denominators, the fundamental principles agreed around some of the issues that are pertinent today. The first one, I think, is very interesting. So fascinating working in international bodies is that you've got to read between the lines about what each word and phrase means. In diplomatic language, certain words have very clear signals. So accelerate international cooperation in today's modern world, that's a slap on the wrist for some. We really need to accelerate investment is a slap on the wrist for everybody, especially the finance and treasury people. So the issues then. So shortages in education and employment. Absolutely, we know the reality. Decent work. Decent work has really come to the fore since COVID and the post-COVID period. Decent work and the appreciation that we have to do better as employers, as institutions, as government, as stewards, to create an enabling work environment for all reasons. Occupational health and safety, protection of sexual exploitation, abuse and harassment, particularly against women and early career women, safety and protection of all health and care workers, the care economy, spurious contracts. So a real big focus on this. And more money and prioritize investment in education, training and employment and retention. We keep forgetting. It's pointless producing new graduates if we're going to put them into a workplace which is toxic, which puts them into a workplace full of the traditional hierarchies, full of the politics and the politicization, and additional demands, informed patients with their misinformed AI applications, etc., etc. How do we look at retention? And therefore, if we're doing that, what is the role of stewardship? It's not the role of regulation, it's the role of stewardship. Regulatory authorities need to rethink what we learned from COVID-19 around the world. Regulators have the huge potential to improve our health and care systems if they have agile, flexible, just the moment, right in time regulatory frameworks. When it's, systematized legislation requiring parliamentary or monarchy to approve regulatory authorities, it becomes too tight. And that COVID taught us that in a big way. And the big other issue, to harness digital health and AI opportunities. Because what we're seeing around the world is this explosion. In every conference I go to, every country I go to, digital, AI is the thing. Of many people who may have been at AMI this year in Barcelona, a whole conference program, all the posters, digital AI. And we believe now, from WHO's estimates, our market, your market, in health professionals' education is now about $300 billion per annum. $300 billion per annum in spending, investment into education for health professionals. Tuition, digitization, AI, product software. That's grown from about 140 million in 2010 when Julio Frank did the Lancet Commission on medical education. So it's a phenomenal increase. But are we getting value for that money? Are you getting value for that money as the end users of those investments to actually make our graduates better for the workplace of tomorrow? Is this graduate fit for the future? And in the last 10 minutes, I just want to give you some of my reflections then, part two of this. If you take all that global picture, if you take some of those realities of the world of work that we're in, the world of health and care that we're in, what might it do when we look at a country application? And that's one of the questions I get most often in my job. It's, we have a system that ministers can literally pick up the phone and ask us any question around the workforce issue. And so my working week is inevitably fielding inquiries from ministers of every upper, middle, lower, high-income countries. What do we do about X? What do we do when our doctors go on strike? I think Shona was talking about for the first ever time. Or our nurses go on strike. Should we pay them more? Should we not pay them more? Should we follow what Scotland did in terms of breaking the strike and investing in our nursing workforce? Or should we follow, some of the Jeremy Hunt principles and saying, actually, no, I know better. We will break the strike no matter what. What's the evidence for that? What's the evidence around mediation? What's the evidence around this? So how do we take all that evidence into our policy and practice? And I want to pick on the example of England. Apologies to Northern Ireland, Wales, and Scotland. But obviously, in terms of reading from Switzerland, what is the dominant issue in your newspapers, your media? What's on the BBC Channel 4 at the moment? The 10-year health plan Fit for the Future is dominating what I'm reading from Switzerland. So let's look at that as an example. But it's the same process that we go through with every country. Global evidence, international context. Lord Darzai, I think his conclusion that the NHS is in critical condition, staff demotivated and demoralized, I think any one of you could have told him that. Did it need a special commission to tell us what we already know? Probably not. But it's on paper. It's there. Then we go into the ambition of what could be potentially there for the next decade. The biggest and best employer. Staff being enabled and empowered to drive reform. Prioritizing UK medical graduates. And this big policy statement around migration, reducing to 10% the international medical, or all international recruitment, not only IMGs, but reducing that to 10%, which I, almost fell off my stool. I don't know whose advice that was to a minister, given where you're currently starting from, to be able to shift the needle that quickly without disrupting health and care services or your education services. And the expansion of medical places targeted to opportunities in all economies, not just in the urban centres accordingly. From that, you've just had the first consultation on the 10-year workforce plan. Hands up who submitted evidence. Anybody? Oh, yes. Okay. So we've got an audience that knows some of the issues from the consultation document and some of the potential challenges. And some of on the left-hand side there, the different areas that the Department of Health was asking for around evidence from you as key stakeholders in this process. Some of the language in the consultation document, again, and I come back to this is perhaps it's because of the work experience I have in Geneva, where diplomatic language matters, where every sentence is saying something. We look at language. And so some of this language is potentially an opportunity. Others we may have to look at with a bit more insight and foresight. Again, to go back to the data. It goes back to my suggestion about 41 people with the first name doctor. Let's go back to the data and actually understand some of this. So I want to look at this from a perspective. We've got the quantitative data, but some of the qualitative perspectives and theories that as educators worldwide are often using, and which pervade some of the medical education and health professionals' education thinking, but not always. And if we look at this transition from the 1960s into the 1990s, 2000s, into the early 2010s, late 2010s, some of the education approaches going from human capital theory, human capability theory, into human economy thinking. And if we then look at some of this language through that lens, through that framework, what might we see? And these are different approaches to help us understand some of the language that is coming from the consultation document. The big shift from human capital to human economy thinking in education is that we are not producing people to produce profit, monetized economics financing. We are producing our graduates to have the competencies and the capabilities to expand human ingenuity in their practice roles to benefit the people, the communities that they serve. And that's part of the Fit for Future language for the people we serve. And so if we look at that, if you come back to the people we serve must include the workforce as well as the beneficiaries of that work. It can't just be the patient population outcomes that are the first priority. It has to be prioritizing in a new modern economy, has to be prioritizing the people at work. And there's a difference between workers, and labor. Many people in our health and care economy are working, they're providing labor, but they're not at work. They're doing this in their additional time. Family caregivers, people looking after neighbors through voluntary work, people doing volunteer systems. There's a lot of labor which is not work in the conventional definition. And if you ignore that labor, if you ignore that human interaction to provide human benefit, and Jamie is going to be talking about social justice tomorrow. Please make sure you come to his keynote. There's a lot of similarities between some of these ideas. If we ignore that, we do so for the disbenefit of our future graduates and our future populations. So we're looking at really pushing human benefits. So what if we look at the language from these two lenses, this transition of thinking over the last 50 years? What if we look at that? And let's half full, half empty. You know, you've always got to give a balance. When you're trying to convince a minister for one policy direction or other, you can't just go with the solution is. Here's what the evidence can say from different vantage points. So there's some alignment with the human capability, human economy thinking. Language of potential and thriving, positive. The language around quality, decent work, very consistent with some of the latest thinking around if we want to hit retention figures better, we've got to focus on that. There's a procedural thing, engagement in making sure those people with their hands up that you're all participating in this, so that we really are able to maximize, optimize our human knowledge, our human insight, our human experience. Not only what the data tells us, not only what the AI models tell us. And there's this opportunity around what we can be and do. So we can be better in our practice environment with these incentives of human benefit and driving some of that work. On the half-empty perspective, you've still got some dominant economic assumptions in there. Productivity of 1.52%. I mean, for those who are in the business of delivering those productivity targets, I wish you good luck. It is an ambitious undertaking to be hitting 2%, 2%, 2% incremental. You know, in 10 years, your average exponential growth rate is going to be almost 30% improvement. That's phenomenal ambitious in terms of where you're trying to go. The assumptions around clinical practice, AI, relieving work, again, still unproven, untested. Total triage, will it work? Yes, no. Does it create work? Does it remove work? You're still finding out some of these things. And how are your graduates going to engage in that process to get it done? And there's no explicit, I talked about the care and caring and the economy and our roles, and especially around the world, the evidence is, you know, our weak health and care systems worldwide, those that are underfunded, survive on the labor of women, on the labor contribution of women, unpaid hours. That's the reality. Stark figures from the IMF, the World Bank, WHO, and the ILO. And if we don't explicitly address that in a forward-looking policy, we'd be saying to ministers, you're not accounting for one of the most critical factors that the evidence tells us. And so, if I was to just be a bit provocative as you go into your 2 days of discussion and try to tackle those burning issues that you have here to face, from all that global evidence, from some of this quantitative appreciation and this theory approach, you are, from an optimistic perspective, there is an opportunity. You've got some language in this document which is around capabilities and capability awareness. You have some opportunity about human interaction with AI and the role of human ingenuity optimizing AI. Not AI replacing people, but people as stewards of these tools and this new technology to make work, the workplace, and the human benefit outcomes more beneficial to all. For you as deans and clinical leaders, the opportunity therefore, obviously the consultation will continue, and I really encourage both those stewards of the policy and the participants in the process to really engage in this dialogue. But for you as deans and clinical leaders, or as other stakeholders in this thing, an opportunity to really think and question, are you in this productivist mindset in your universities? Targets, productivity, performance. Or actually, are you really deep-seated believers of some of the human ingenuity, human benefit perspective, which most public health professionals join their institutions with that belief first and foremost? How do we put that back on the policy table to make sure that we're developing people who are competent, capable for that? How do we protect our workers? How do we protect their voice and their opportunities to come further forward? And how do we create a workplace, again, where humans and AI give us that leapfrog that everyone keeps telling us that AI potentially will bring? And these are questions that are happening in most jurisdictions, most ministers' offices, most conferences around the world. So you're not on your own. But if you find the solution, please let me know. Thank you very much.
Okay, wasn't that spectacular? How to look at things differently. Now, do we have any questions? We have a few minutes. Okay, while we're waiting, I'm going to take chair's prerogative. Jim? In your experience, what's the best way to influence politicians before they declare policies?
I've been doing I'm a bit of a data nerd, to be honest. I confess it, I'm sorry. I've been doing some work looking at the politicians. Retention's a big issue around the world, we all know. So I looked at the survival rate of our ministers. And in the last 10 years around the world, the survival rate, if you're a Minister of Health, Secretary of State for Health, is 19 months. That's the average. UK, you're an outlier. So there's just high attrition turnover of ministers. And so how do you get a wicked problem like education and employment in our health and care economy, which needs long-term policy? How do you get a minister to focus on that? And it's extremely difficult because people around them, the contemporary issues that the Daily Mail or any other newspaper wants to talk about are not the long-term fixes. They're the short-term problems. And I think Jeremy Hunt's realization that his biggest failing as minister, and he's the longest-serving minister, Secretary of State, that his biggest failing was not addressing the medical doctor issue properly, is a reality. It's a lesson he learned after he left. But he didn't fix it when he was Chancellor, and he could have done. So it's a tough one.
Okay, question at the back.
Thank you very much. Have you got a simple starting point for how to create a better working environment, something that we can take home, something tangible? I think it's a very stressful work environment.
Exactly. We managed to get a couple of years ago, and again, 194 ministers' consensus to a document which was the Global Compact on the health and care workforce. And a global compact in international diplomacy is something a little bit more than just a decision or a resolution. It's an undertaking. It's a compact between jurisdictions. And that document sets out the international legislation, the international responsibilities, the moral and ethical obligations of governments and employers to create decent work in the health and care economy. And it was hundreds and hundreds of documents consolidated down, simplified into language the ministers could understand, and then put into a format which just sets out a very simple 4 quadrants, 16 areas of action. And there are areas of action that every employer can take on that. So as a reference document, use it as a conversation starter, and then pick 1, 2, 3 issues. Don't try and pick all of them. 1, 2, or 3 issues which would have the biggest impact in your employee's workplace and work environment.
Thank you. One last question. Thank you.
Hi there. Thank you very much for your presentation, especially as an SHO who wants to be thought of more as a future leader rather than a number to maintain minimum staffing. But my question was more to do with your first part of the presentation, when you were talking about recruitment and especially ethical recruitment, because obviously 40% of the workforce comes from international medical graduates, and our Chinas and Indias can sustain that. But I believe 9% of it is from WHO red list countries. So is the WHO or any international body able to enforce change on higher economic countries to actually not so much punish, but curve away from unethical employment for that 9% that talent is really draining from their countries? So that's my question.
No, good question. Just clarification. So the red list is not WHO. The red list is the Department of Health and Social Care. And in much of the media, it gets used as the WHO red list, but it's not. It's a UK red list. The sovereign responsibility for that list is the department's code of practice. The global code of practice has a grouping of countries which require support and safeguards before recruitment happens. But the international code is that it's a code of practice. It's not a compulsory instrument with a consequence. It's about what is best practice of ministers to do it. But you have to remember, your ministers around the world, whether that's in any of the countries here or in Europe, elsewhere, their first responsibility is to provide health and care to the population. They're meant to be doing that in a moral, ethical, public health way, in theory. But their first responsibility is that. So it's trying to encourage people to do good practice rather than, it's the stick and the carrot approach. And there is no consequence. But the UK code actually does have consequence. So if your private employers recruit from those countries, active recruitment, they can be struck off the NHS employers list, and therefore there is a consequence here in the UK for that. But that's the debate. Andrew Mitchell and Becky Dodd are co-chairing the all-party parliamentary group to have that conversation, the third hearing tomorrow in Parliament. So it'll be fascinating to see what their recommendations to Wes Streeting will be.
Thank you. Shona, do you want to say anything?
Not other than thank you. I think it's our responsibility to lift our heads up and look across the globe. And our learners are demanding that we do that. So I like the way you finished it at the end with some of the positives. And we always have to look at where are the positives, because actually some of the statistics you share are quite stark. But there are positives. It's how can we all influence? We all have to influence, even when we feel tired and a bit ground down. We have to continue to input in. And thank you very much, Jim, for showing us why it's worth it.
Thank you.
Thank you.
So, we are at the end of the session. We've got 40 minutes refreshment break. I don't think I need to encourage you lot to mingle and network because that came out big on the word cloud, but please do that. There is a fireside chat this afternoon. Don't forget to ask your questions via the app for the chat panelists, and you can type in your questions until 1300 hours today. I have explicit instructions. After the refreshment break, we will have the first of our 4 blocks of parallel sessions, including a selection of workshops, symposia, and oral abstracts. And we want to thank everyone for submitting, for coming along, for judging. It's a wide and varied programme. You can also see the ICC as a large venue. Please give yourself plenty of time to find your parallel space and the seat before the session starts. So all that remains is have a wonderful conference. See you soon.